Good morning. I'm Amy Cornelia, and I'm Director of the CFAR Social and Behavioral Sciences Core. I am here to moderate the first session, Equity, Social Determinants of Health, and Human Rights Issues in HIV and Research. And we really have two just excellent speakers for this morning's sessions. I think you all will both enjoy, both Lauren and Rosa. So I'd like to introduce you to our first speaker, who is Dr. Lauren Brinkley-Rubinstein. Lauren is an associate professor of population health sciences here at Duke and a recipient of the CFAR Faculty Development Award and a CFAR Supplement Award. She conceptualizes her criminal legal justice system as the structural determinants of health that impacts people, families, and communities. Her work focuses on substance use, HIV prevention, and underscoring how mass incarceration is an integral facet of structural racism. Today, Lauren will share her insights on the HIV and criminal legal system.
Thanks, Amy, and thanks for having me, everybody. I have been at Duke for 9 months, so thanks for having me in the bigger way, and thanks for making me go first. I appreciate that. As Amy said, I'm trained as a community psychologist, so I really do think about people nested in families, living in communities, bounded by time, geography, policy. I'm running around thinking about the social ecological model and how criminal legal systems really are cross-cutting across people, families, communities. And today I'm going to talk about sort of the broader context of incarceration in America, why that's important, how mass incarceration or hyper-incarceration acts as a structural determinant of health, as a facet of structural racism. And then I'll talk a little bit about what we know about HIV treatment and prevention, and then a little bit about the portfolio that I'm working on and how what we found over the years has really led us down a certain path. Okay, so before we talk about HIV in carceral settings, we really have to set the scene. I think a lot of people underestimate the ways in which the carceral system impacts all of us. And this is a little pie chart that shows how many people are incarcerated if we look at any given time in any given year. So if we looked right now, this is about the number of people who would be in jails and prisons across the country. And just to make sure we're all operating in the same baseline knowledge, jails are short-term facilities that people tend to be in for a shorter amount of time. It's people who are serving shorter sentences, people who have not yet been sentenced who are awaiting trial. Right now, there are about 600,000 people in jails. In state prisons, federal prisons operated by states or the federal government, there are more people. These are folks who are serving longer sentences, usually a year or more, and there are about 1.3 people right now in our state and federal, in our state prisons, and then a smaller number in our federal prisons. And this doesn't even account for people who are on community supervision, which is probation or parole or post-release supervision, and that's about 4 million people. So lots and lots of people at any given time in our carceral setting. And this doesn't account for the churn that exists in jails. So if we look at any year, about 10 million people in America cycling through jail. So just a massive number of people caught up in our carceral system. And we can't talk about the carceral system if we don't talk about racism, if we don't talk about the ways in which Black and brown people are disproportionately targeted by law enforcement and later incarcerated. And many of you have maybe seen this. It's kind of dated at this point, but the point still stands. If we look at women and men, massive disparities in the number of people who are Black who are in the system, and this doesn't have anything to do with crime rates, especially, if we look at substance use, we see that white people often use substances more than Black people. It's really where police are patrolling. Okay, when we think about the context of HIV, there in any given year, again, about 1 in 7 people with HIV cycle through our carceral system. The prevalence of HIV is 3 times higher in people who do find themselves in jails and prisons. And we also see this represented, this disparity represented in other types of infectious diseases. This is a really important paper that came out in 2015, and it shows the HIV continuum of care among people who've experienced incarceration. And what the important takeaway here is that if you look at ART and viral load, you can see that before incarceration, things are not great. It gets a little bit better in the context of jails or prisons, usually because you might have access to ART in ways that you didn't in your community, which is in some ways an indictment of community care. Because quality of care and access to care inside of carceral settings is not great. The important takeaway, though, is that on almost all of these metrics, if we look at post-release, we're often doing worse than before incarceration. And so there's this collateral impact on ART, on the HIV care continuum after incarceration. And that's for a number of reasons. So as I said before, access to ART in the community is often difficult. There's a lot of stigma related to HIV, as we all are very well aware of. But then there's a lot of stigma related and discrimination related to being involved in the criminal legal system. And so those intersect and can often create compounded stigma. There's often a need for addiction treatment, and there's a great relationship between access to substance use treatment and HIV treatment, the need to sort of think about those in context and in concert with each other. And then our group has done a lot of work, I'll talk a little bit about this later, about competing needs. And so, as many of you may know, once you're released from incarceration, the punishment doesn't stop there. People often have a hard time accessing housing, accessing transportation, other types of benefits, reestablishing networks or social support from family or friends, and all of those things in many ways supersedes your wants and desires to go to the clinic, right? You need to find a safe place to sleep first. So here's some of the work that we've done related to pre-exposure prophylaxis. When I started this path, no one was really looking at PrEP in jails and prisons. Did my postdoc at Brown, and we started to look at what was happening in the Rhode Island Department of Corrections. And so we implemented a screener that was put into intake. So anytime anyone came into the Rhode Island Department of Corrections, we screened them. And this is a few years ago now, but a big majority of people had never heard of PrEP before. And there were some disparities between white and black folks around that knowledge. A small percentage, but kind of a meaty percentage, 21% of these folks that we surveyed were interested in learning more about PrEP, and that also looked different depending on what their HIV risk profile was. And then we asked them if they would take a daily medication. About 22% said yes. So some interesting and optimistic results around the implementation of PrEP in carceral settings. We followed this up, so that was in Rhode Island, which is a very unique place. Rhode Island is different than a majority of the United States in a lot of ways. Their carceral system is very different. They have a unified system, so there's no such thing as a jail in Rhode Island. So if you get arrested, you go to one campus. So the whole state is unified. It's easier to implement innovative programs there. So we thought, well, what if we do something in a very different setting? And this is in Little Rock, Arkansas. So we asked women at the Pulaski County Jail similar questions about PrEP. And you can see here a larger percentage of folks had never heard of PrEP. A smaller percentage were interested in taking it. And there were some, most people had not sort of engaged in any HIV prevention other than PrEP. So like thinking about HIV testing, et cetera. So then we were like, okay, let's do some qualitative work back in Rhode Island to try to understand what we found in that screener. Let's see what a specific population of people in the Rhode Island Department of Corrections might think about PrEP. And so we interviewed 25 men who have sex with men who are incarcerated currently in Rhode Island. And these are the things that came up for them as barriers to PrEP in that specific carceral context. So concerns about costs of PrEP medication, even though they would assume that the Rhode Island Department of Corrections would be covering that cost, but some worries about that cost being transferred to them. We hear this in other contexts too, but thinking about stigma, family disapproval, what if someone finds out that I'm on PrEP? And then thinking about after release, all the same barriers that we hear in the community reentry context. So how would I get to the clinic? I don't know where I'm gonna live. How can I think about PrEP? And then really this compounding hardships. I have to go get my new ID. I've got to go figure out where to live, et cetera, et cetera. And then really what came up as very important is a lot of people said, well, I could get on PrEP, but I'm really worried that the police are gonna pick me up again. And if they do, they're not gonna give me PrEP at the Rhode Island Department of Corrections, so why would I even start? So this is sort of a summary slide to just say that there are lots and lots of obstacles to PrEP and to ART among people who are incarcerated or have been incarcerated. And oftentimes people really need to think about the hierarchy of needs that they have in community reentry. And something like PrEP in particular often doesn't rank high enough, and I'm not sure it should. And so thinking about interventions that couple all of these community competing needs is really important. Okay. So what did we do? So when I first got to UNC 6 or 7 years ago, I wrote this grant, which is the first criminal legal cohort study relevant to PrEP. And so it's the SPEC study, the Southern Pre-Exposure Prophylaxis Cohort Study. We have sites in the Triangle, in Miami, and in Lexington, and we're almost done. We have about 400 people, 364 to be exact, that have been enrolled. And what we did was we recruited people from the waiting rooms of probation or parole offices, and we told them a little bit about PrEP. We screened them for HIV risk using CDC guidelines, and then we enrolled them, and we told them about their local PrEP clinic. Well, so now we're 5 years into this study, 4 people ever went to a PrEP clinic. So nobody, essentially, which is a major finding, I think. It's not what we expected, but it also is kind of what we expected because of all this work that we had done to figure out all these competing needs in the community. And so we've dug into why that might be. On average, among our 364 participants, people had at least 4 competing needs. So those are other things that are going on in their lives that they feel like are really important and need to be addressed. We have also done some work looking at sort of the CDC risk screener and people's own perception of their individual risk, and there's discordance. So a majority of people really didn't think they were at risk, even though they screened into the study based on risk. And we've also done some work around whether people would be interested in other types of PrEP, right? So maybe not the oral medication, maybe thinking about long-acting injectables. And there seemed to be a lot of enthusiasm for LAI options. So that really has opened up a whole new line of research that we're walking down now. As Georgia said, we just got this EHE supplement to do some work. And we're really trying to lay the foundation to get the right community engagement, the right voices at the table, so that if we do a future intervention, we'll know all the right questions to ask, all the right components to include. And we now also have an R34, so a pilot clinical trial that is going to happen in the Baltimore prison system, where we're going to do some qualitative interviews, which we've begun, and with people who are incarcerated, with stakeholders who are administering medical programs inside of that system, to ask these same questions. What would work? What wouldn't work? What kind of needs do you have inside of these settings? What concerns do you have about post-release? And then we're going to create an intervention to give people that first shot upon release and then follow them into the community, randomizing them to long-acting injectable versus oral medication. And that'll be happening in the next couple of years. And then we've just also submitted one of those strange mechanisms in R3361 in response to an RFA to look at the co-location of long-acting injectable PrEP plus extended release buprenorphine. So really trying to get at medications for opioid use disorder and HIV prevention all in one place. And we're doing that in the Baltimore prison system and also in the bordering county jails to DC, so Prince George's County and the Washington, DC jail, which is very important because DC has such a high rate of HIV, and the jail certainly has a high number of people who are at risk and also have HIV. So in conclusion, I think if you take anything away from the talk today, it's that a massive number of people are in the carceral system in this country. It has deep legacies of racism, really from slavery to Jim Crow to mass incarceration. It touches all of us, millions and millions of people cycling through the system with low quality access to healthcare, and that includes HIV treatment or prevention. And I think as providers, as researchers, always thinking about how incarceration might impact people's health outcomes, might discontinue their ability to engage in prevention or treatment, is really important. Thanks so much.
Okay, we have time for a few questions.
Really phenomenal talk. I'd love to catch you afterwards because you mentioned my other favorite virus, which is hepatitis C.
Yeah.
Where, as you mentioned, there's a significant overlap in terms of not being able to access care. But I want to go to a quote that I pulled out of one of your slides, which is that the existing approaches to HIV prevention are insufficient. And in the HCV world, right, we're trying to think about how do we stop doing this the same old way. Because we're not getting to people. And so do you have thoughts? I mean, trying to get to people who are part of the justice system is obviously a key way. But once they're out of the justice system, I think there's a high risk of losing them, as you showed. Do you have thoughts, or are you also testing, how do we get to people and provide care without expecting them to come to a clinic or to come to a tertiary care referral center to assume care?
Perfect question. Thank you. I really should bring Mary McKellar up here, who's doing that work, who really is thinking about non-traditional avenues for provision of care. So I have a couple of things. So one is, which is maybe a controversial opinion, but we screen people for PrEP indication based on this risk, this kind of embarrassing set of questions that I wouldn't want to answer in front of my doctor. The World Health Organization has this conceptualization, which many of you probably know, as substantive risk. And if you have been incarcerated or you belong to a demographic that has a heightened risk, heightened prevalence of HIV, then you just are clinically indicated for PrEP. So if we took that and used that, anyone you knew who had been incarcerated, you could just say, can I give you some PrEP? You don't have to ask them anything about behavior. And I think that would make people much more likely to engage in a conversation about it, much more willing to take it. The other thing is really just, these non-traditional ways of providing care. And so we're doing some work trying to think about syringe exchange sites, pharmacy provision. So in our R34, we're thinking about, for long-acting injectable ART, can we have a pharmacist on board who can administer that? So I think it is really important to think about how to get back out into the community rather than giving people a referral, telling them to show up. And we know they have too much going on to make that happen.
Well, Lauren, welcome to Duke, and this presentation really talks about what a great move it was to get you to join us. So thank you. I think one of the areas that we have probably underappreciated is the role that mass incarceration particularly has played in driving incidence. And that is not, people thought maybe people are acquiring HIV in prison. It really doesn't relate very much to that. It really relates to the problem of the substantial number of people who are virally suppressed while incarcerated, particularly in prison, and then fall off and have treatment interruptions. And treatment interruptions, lead to very high viral load. And essentially, we have been returning citizens who are almost like seroconverters, into populations, really oppressed by mass incarceration. And I think that at least partly explains the otherwise very hard to understand high risk for African American women for acquisition, even though pretty much every study has shown they have lower behavioral risks than white women. And it's just hard to understand otherwise. So I think that's an area. I don't know if this is an area of interest to viewers or of others, but it's something we alluded to. We did a Lancet series on HIV, Hep C, and Hep B in prisons globally, and this emerged as a really important area. But I haven't seen anybody take it up.
Yeah, it's such a great point, and you said it so brilliantly. It really is true that not much transmission actually happens inside of jails and prisons. Some, sure, but it really doesn't happen as much as we might think it does. And it's really that post-release period. And I think that's why formulations such as long-acting injectables are so important, because you can set people up with that before they leave, and then you can have very intentional connection to treatment post-release to get them to that second shot. In the absence of that type of formulation, I do think it's really important to engage in medical discharge planning, which a lot of jails and prisons just don't have at all. And so thinking about intense an important linkage. We've got some work going on in Durham related to primary care and medications for opioid use disorder using community health worker interventions, and they really work because they both get you to the clinic, but they also are forming relationships with you that help you figure out all these other things in community reentry. They know how to connect you to the housing folks to get you a safe place to sleep. They know how to get you a bus pass. They care about you as a person, and they're investing in you. And so I think there are nice models that can be applied to HIV. It, of course, has been done before, but maybe more universally funded.
Good morning. I look at things differently. I'm a part of the D3C.
Yeah.
Lauren, when you first talked about people in prison, the difference is when they're in prison and when they're out. And this is speaking from experience. When you're in prison, they take you all the time to get your medicine. And you don't have to worry about insurance. And you don't have to worry about what time you take your medicine. And then life doesn't show up because you're on a cycle every day and you know what your routine is. So that was one of the things I wanted to say about that. The other one is one thing that no one ever wants to talk about, and this is related to females, is survival sex that men have in prison. No one wants to address this and talk about it, and I don't understand why. Because I think that's one of the reasons, me personally, feel like because men are too ashamed to talk about that they had to have sex while in prison to survive. And some of those maybe having sex with HIV positive people, that you can't come home and say, look, I had this, and this is how I contracted HIV, and some of them may or may not know. The other thing is, back in 2018, PrEP wasn't, and I don't know if the prison system gives PrEP out now or would be able to, but PrEP wasn't, injectable PrEP wasn't available in 2018.
Yep.
So I wonder what the numbers would show now if the PrEP, injectable PrEP was given out in prison. And let me see. As far as the cohort study, and I can't even read my own writing, please forgive me. Back in 2012-13, when I worked for Triangle Empowerment Center, we had a gentleman come up from Atlanta and was talking about Black MSMs. And one of my thoughts were, what's going to happen to these people once the study is over with? You know, and I think a lot of times when we do cohorts and put people on clinical trials, we don't think about the after effect. While you're on a clinical trial, you have to take your medicine, and the driving force, because me speaking from experience, has been in the past, I needed that money. So that may be one of the reasons people stay on PrEP. But you have to contact people. Your access is different. And then the other thing, once you are in a safety zone, so to speak, because that's the safety space for them, you have to deal with stigma also. And a lot of people don't want to deal with stigma. And here we are at 2023, and a lot of us are still dealing with stigma. A lot of us are still ashamed to talk about that, hey, I have HIV. And a lot of people will go several miles away from where they live to get their HIV treatment. And a lot of times you all as clinicians and scientists forget the person as a whole and what they go through on a daily basis. Not wanting to let their family know because of stigma. The access. I think it would be great if we could all do away with the pills and do the injectable. But I was thinking about, because I'm a very big advocate for women in PrEP. I would be glad when they'll have a vaginal PrEP for women. A lot of women, and I'll speak personally for myself, my daughter is married and she's in a situation. She would love to take PrEP, but her thing is, What if her husband finds out she's on the pills? What kind of questions would that bring up? If she takes the injectable PrEP, her injection site will be sore. And then her husband's going to have questions about that as well. So I really like the idea of the vaginal PrEP ring, if we can ever get it in the United States, because she doesn't have soreness from the injection. She doesn't have to hide her pills. And this way she can feel confident that she's protected, whether she's in a relationship or not. And so these are just some of the thoughts that I had. Thank you.
No, thank you so much. There's so much there, so much wisdom. One thing I'll maybe comment on is just to underscore the importance of researchers and clinicians not walking away when the trial is over. So really trying to build deep and important relationships with community and community-based organizations, clinics in the community, so that whatever you have provided becomes standard of care. Yeah, thank you.
Thank you, Lauren. And thank you, Rita, for your comments. I'm always happy or appreciative of your perspective on things. And for those of you who don't know, Rita is part of D3C. And so she's someone just to get to talk to and hear her perspectives, because she has a lot to share and it's really, really useful. So I've known her for quite some time and always like to see her, but like to hear her perspectives on the work that we do.